Hey, what's up, fellow ambulance corps? It's John Barr back again with another episode here. This time we'll be talking about hyperactive delirium with severe agitation. As usual, we're here to educate only. Please take a few moments to look through the disclaimer. Alright, so let's get into what we're going to talk about today. First, I'm going to define what this syndrome is, discuss the goals of pre-hospital treatment, discuss some initial therapeutic options, and I am going to talk about ALS interventions to this, including medications, because I think it's important that as EMTs, you still understand what can be done or things that ALS could do for the patient and how you might be able to assist in these types of cases. And we'll also talk about the underlying triggers and things that can lead to this presentation. So why are we talking about this? I was inspired to talk about this because the agitated patient is one that's fraught with peril. It's perilous to you as providers, it's perilous to the patient, it's perilous medical legally, and many of you may have heard about this case. It was widely featured in the news in Colorado, where two paramedics were convicted in the death of Elijah McClain after a ketamine administration, and interestingly, they were criminally convicted, with charges of criminally negligent homicide. And historically, medical malpractice has been predominantly civil cases, but this is yet another case that's now been taken to the criminal realm. So I'm hoping by educating you more about this topic, you can keep yourself safe, keep your patients safe, and avoid some of the issues that occurred in this particular situation. We're not really here to second guess or relitigate this case. I'm here just to tell you about this topic, and I just want to stress the importance of it because it clearly has major implications. So first of all, what is hyperactive delirium with severe agitation? So some of you may be picturing like this guy when you hear about this syndrome. You may hear the terms superhuman strength, extreme anger, violence, yelling, confusion, agitation. Sometimes you might picture this, but there is an official definition to this syndrome, and I'm pulling from the ACEP, which is the American College of Emergency Physicians 2021 Task Force Report, which describes this condition as a syndrome marked by disorientation, aggressive words or actions, and most notably, ACEP designates this as a life-threatening medical condition that demands emergency medical treatment. And other things that can characterize it are signs of sympathetic or adrenergic excess. So this is high blood pressure, high temperature, agitation, confusion, and in the hospital you can find metabolic derangements associated with this. And just to keep you guys up to date, ACEP did put an update in 2023 affirming the terms hyperactive delirium with severe agitation. Notably, and look at the area I've underlined here, they recommend against using the term excited delirium. And this is, you may have previously heard agitated delirium or excited delirium as terms used to describe this syndrome of severe agitation. These terms were problematic because they were used in and of itself to describe a cause of death, whereas what this really represents is a type of delirium, and delirium is caused by an underlying medical condition, and that condition should attempt to be diagnosed and treated. So I would suggest you use the term hyperactive delirium with severe agitation as outlined by the American College of Emergency Physicians, in particular in your charting and in your general discussion of this topic. So as I alluded to, other terms that were used previously to describe the syndrome, excited delirium and agitated delirium, I recommend you strike those. So we mentioned this a little bit, but other characteristics of this syndrome include disordered thinking. What disordered thinking means is the thought process is hard to follow. There's often psychomotor agitation in association with this. We talked about hyperadrenergic state. So imagine, being super up, okay? Combative, violent, they can also be loud. And in particular, the combativeness and violence is what contributes to the danger for you, for the patient. And so we're going to work on managing that. So when you encounter these patients in the pre-hospital setting, there's three main goals. One, protect yourself. I still remember to this day the 16-year-old version of myself at the Bergen County EMS Training Center, and I remember very first day they had made us all say out loud, the most important person on scene is me, and that was a lesson in scene safety, right? You need to keep yourself safe, your partner safe, and everyone else. Okay, so step one is in these situations is you need to be mindful of unsafe scenes and keep yourself and everyone around you safe. Our next goal is, once you're safe, is to try to prevent morbidity and mortality because these patients are at risk of death. This is a life-threatening syndrome. Okay, and well, it's a life-threatening syndrome that's caused by some other life threat. So this is a dangerous situation that you need to get under control. And lastly, in most of these cases, the pre-hospital outcome that you want to happen is the patient to go to sleep so you can get them to the hospital. Now, how are you going to do this? So I think to understand your options in the pre-hospital setting when treating this condition, it's helpful to think of hyperactive delirium with severe agitation on a spectrum. On one end, we have like a match, right? It flames up, it burns for a very short amount of time, it burns itself out, and doesn't really require an intervention to go out. It'll just burn out in a couple seconds if you leave it alone. Okay, that's kind of the mild form of this. Then in the middle, you have the burning popcorn. Now this, if you don't address it, it's going to turn from smoke into full-blown flame. And not only that, the smoke is setting the fire alarm off. Other people in the area are now being affected. They're hearing the alarms going off. Maybe the building has to evacuate. It's now it's grown out of control to the point where it's impacting other people. And this will not fizzle itself out. You need to address this in some way. It's not going to be self-limited. And then in the far end of the spectrum is the full-blown structure fire where there is an immediate risk of death by burning and smoke inhalation and heat injury, and this needs to be addressed immediately. This is immediately life-threatening. This is a major emergency. So what are the types of patients that fall into these categories? I'm going to give you some examples to try to help you understand the spectrum a little better. And again, please understand it's not a spectrum, and please understand that it is a spectrum, and there's going to be overlap in these situations, and the patients can progress from one end to the other. So for those match type patients that kind of fizzle out on their own, I want you to picture like a drunk college student. They may be a little aggressive in the beginning, but they're redirectable, and if you just wait them out, they'll sober up and they're going to be okay, right? And these patients just require verbal redirection, maybe some distraction. A key characteristic of patients in this stage of mild agitation and mild hyperactive delirium is that they can have a conversation with you. You can talk to this type of patient, okay? So you can talk to them, you can try to talk them down, you can try to distract them, and often that's all that's really needed, and this can be done at the BLS level, right? Now, let's talk about that microwave situation now, okay? So now you're getting to the point where we really can't have a rational conversation with the patient. They're not distractible. The situation is escalating. It's affecting other people. And the first step you're going to need is usually some type of physical restraint. And this is where law enforcement can be your ally. And physical restraint is extremely dangerous. All three positions you see here, prone and hogtied, handcuffed behind the back, and leather restraints and straitjacket, are all no good. Okay? All these positions can put excess tension on the chest, lead to constriction of the chest, impair breathing mechanics, and can lead to patient morbidity and mortality. So if you have to restrain the patient, you want to get them out of one of these positions if they're already in it. They should be supine on your stretcher and handcuffed in the front or handcuffed to the stretcher, okay? Because we don't want the restraints to lead to more compromise of the patient. So again, these are all examples of not good patient positions for this. Now, I do understand, having been in the field and continuing to be a pre-hospital physician now, that the world's not perfect. You need to work with your law enforcement partners on this. But if you find patients in this position, I recommend you talk to your law enforcement colleagues to get them out of this position as soon as possible, to address any threats to airway and breathing, and to adopt a safer position, which includes being handcuffed in the front or to the stretcher rather than behind the back or in any way that restricts the chest or breathing mechanics. Okay, so no prone positioning, no hog tie, avoid behind the back, and no straitjacket. Now, the next step, remember I said first step, you want to protect yourself. So once you have physical force to restrain the patient, protect yourself, the next thing I want you to do is put a non-rebreather on this patient. This is another BLS intervention you can do. Put a non-rebreather on. This has several purposes. One, it provides oxygen to the patient. Two, it controls spit. So if the patient is trying to spit on you, which can be, get you exposed, especially if there's blood in their mouth and your eyes are mucous membranes, you want to control that, and a non-rebreather is the best way to do that. I've seen other people try to put a hand over the mouth. Do not do it. That's constricting the patient's breathing. Also risk of you getting bit. I've seen people try to put like surgical caps or bonnets over the patient's face. Don't do that. Okay, use a non-rebreather. You have it. It provides oxygen. It treats hypoxia, which is a cause of hyperactive delirium with severe agitation, and it controls spit. So use your non-rebreather here. Now, the next step in the microwave type patient, and this is, you're going to need ALS, okay, is chemical sedation. Okay, and typically in this category, you're going to use a combination of a neuroleptic and a benzodiazepine. Now, some, cheeky ICU nurses made this Silent Night Christmas ornament mentioning haloperidol and lorazepam. And while that combination of meds does work, I would suggest we now have better options of midazolam and droperidol, which are also a benzodiazepine and neuroleptic, but they work faster and they last for a shorter period of time, making them better for pre-hospital use. So this is something that can help you gain control of that situation that is, starting to flame up a little bit. You're progressing towards the full-blown fire, that you need to gain control of the situation quickly. And if you see a scene where you think this is developing, remember, you need ALS to get sedative medication, so you want to make that call early. Okay, that way they're on their way and can help you, because you're now into ALS interventions here. And additionally, any patient who is chemically sedated needs a lot of monitoring, and I'm going to talk about that later. Now, if your patient has progressed to that full-blown structure fire situation, this is where dissociative dose ketamine can be life-saving. This is the situation where you need this is where the patient is immediately violent. In situations I've encountered that required this, law enforcement officers were actively having their heads bashed. I have seen other examples of extreme violence where the patient needed to be sedated immediately. Okay, this is the fastest, most reliable way to do it. It's going to be an intramuscular shot. You're going to need ALS. Okay, but I'm telling you guys about it because I want you to know about ketamine. And ketamine has had a lot of controversy in the media for a variety of reasons. Now, when used correctly, ketamine can be a very safe medication. When used incorrectly, it can be a very dangerous medication. So you guys are BLS. You're not going to be the ones doing the ketamine shot, but I am going to tell you about some of the monitoring you need, because you can help with this and prevent morbidity and mortality from ketamine. Now, what ketamine does is it dissociates the patient. What does that mean? It's going to have several effects. One, it does relieve pain. It is a pain reliever. Two, it makes people forget. Three, it relieves anxiety. Okay. Now, it can also cause hallucinations. And ketamine, if you don't get the right dose, the patient can get into what's called the party zone. There are people who try to use ketamine recreationally and intentionally go for that. We need to go at a higher dose than that to the dissociated zone. And really the dosing is up to ALS, so I'm not going to harp on that too long. I'm just telling you, if you have a ketamine patient who's underdosed, they may hallucinate and be high in that party zone, and they may need more to get further dissociated. So I just want you to be aware of that effect. Now, once you get the patient sedated, you can't just drop the mic and be done here, okay? This is where the real work begins because there's a lot of stuff you have to do to prevent morbidity and mortality in this patient. Now, all this stuff up to this point is really about scene safety for you, for your colleagues, and for the patient, right? The patient is at risk of serious injury the more they get in combative spouts with law enforcement or others, or with other people. So this is not the end once the patient's sedated. It's actually just the beginning. And in the post-sedation setting, you need to get the patient on a heart monitor. You can assist ALS with this, and that's a good skill for you to have as BLS, is how to get the patient on a monitor, okay? And it's beyond the scope of this video, but maybe we can make a future video on that in the future on how to do that. Now, all these patients should be put on end-tidal CO2 monitoring. These patients should receive oxygen. Remember that non-breather. They should have their vitals checked every 5 minutes. You can do that as BLS, right? You can help with that. These patients should get an EKG. ALS will need to do that. These patients, usually if there's no other contraindication, should get IV fluids. And very importantly, they need airway monitoring. And as BLS providers, you can make sure their airways patent. You can help with bag mask ventilation if needed. You can help accomplish that. And so you have a role in assisting ALS in the post-sedation phase of care. Now, and I just want to clarify what I mean by post-sedation. I mean after the patient's gotten the shots, okay? This is also really occurring during the period while the patient is sedated. But once they get their shots, then they need this monitoring. And in my experience as a pre-hospital physician in doing quality work, quality assurance, and quality improvement work with EMS, my experience has shown that ketamine, when done properly and treated like procedural sedation, like we would treat it in the hospital, is very safe. But if you don't put the patient on the monitor, if you don't take their vitals, if you're not keeping track of them, this is when bad outcomes can occur. So this is critically important. I can't stress enough how important it is to monitor these patients once they receive sedating medications. And then beyond the post-sedation phase, you also need to keep track of the differential diagnosis for this, because a key thing, a main reason why we use the term hyperactive delirium with severe agitation is delirium is something that is caused by something else. Something else is triggering the patient to have that delirium. Now that could be hypoxia, which is why we put the non-breather on. That could be hypercarbia, which means you may have to bag that patient if they have too much carbon dioxide. It could be hypoglycemia. This is why ALS, you want to check a blood sugar. Okay, they could be hypoperfusion because they're in shock. I have seen patients act like this because they've had gunshot wounds and were in hemorrhagic shock. They weren't getting enough blood to their brain. They were getting agitated combative because of their shock. Okay, and we made a whole nother video on shock, so if you forgot, please go back and check out that one. Okay, they could also just have a head injury, traumatic brain injury, bleeding into their brain. That could be leading them to act like this. They could be septic. Infections can make people delirious. In particular, watch out for meningitis. So if someone has a fever and is acting like this, you want to make sure you're also taking adequate protection for yourself. Remember, meningitis requires droplet precautions. Toxins and drugs. So these are things like your cocaine, your methamphetamines, your PCP. Other toxins can do this. In addition, withdrawal from drugs like alcohol or benzodiazepines, for example, can lead to the syndrome, as can thyrotoxicosis or high thyroid hormone. Now, you're not going to be able to solve that one in the field, but you should know about it, that it's a hormonal abnormality could lead to this presentation. So let's summarize. 1. Hyperactive delirium with severe agitation is defined by ACEP. It's a life-threatening situation, and it requires immediate intervention in the pre-hospital setting to help reduce morbidity and mortality and keep everyone safe. Your safety and the patient's safety are paramount. Applying physical restraint, the physical force, and the chemical sedation are dangerous. Remember, I told you about the dangerous physical positions. We talked about some of the chemical sedation, okay, but they come with danger. That being said, so is having ongoing hyperactive delirium with severe agitation is also dangerous, and so the benefits of chemical sedation will generally outweigh the risks in situations where there is danger. And so you need to be able to mitigate those risks as a pre-hospital provider and manage this. Now, do not forget, there is some underlying cause that's likely triggering this. So remember to evaluate the patient for underlying causes to the extent that's possible in the pre-hospital setting and get them to the hospital where they can be evaluated further for this. So this is a complicated topic. If you guys have questions about it, please reach out to me. I'll try to answer them for you to the best I can. Thank you guys for listening in. Stay safe out there. And if you want to learn more about this topic, I included the references that I mentioned in this from the American College of Emergency Physicians. There's also a great online lecture by Ruben Strayer, who I learned a lot from. And I've cited his lecture here. And he talks a lot about management of the agitated patient. His talk is geared more towards ER doctors, but if you're interested in taking this topic a little bit further, I recommend you check it out.